Thank you very much. Good evening, everybody. Can we turn off the lights, please? I think it will be better, especially that I have to, great, perfect, that I have to show some microscopic picture. So for those of you who are not very familiar with histology and particularly dermatopathology, this is a subspecialty of pathology that studies skin diseases, diseases of the skin, and skin is the largest organ in the body. I will give you some preview. Melanocytic nevi are benign melanocytic lesions, melanomas malignant. There are different types of melanocytic nevi, and in 1948, Sophie Spitz, a pathologist from Memorial Sloan Kettering Hospital in New York, noticed that young children present with these bizarre, under the microscope, melanocytic lesions. The cells of these lesions were large, epithelioid, in other words, they resembled keratinocytes, epithelial cells. They were very pleomorphic. They differed in size, shape, and staining characteristic. They had great big nuclei, prominent nucleoli. And based on these characteristics and numerous mitotic figures, she thought that these were melanomas, and she called them melanomas of childhood. 13 cases in her series. Here are some pictures from her original publication. So she believed these were melanomas of childhood that behaved well because none of the children died. Later, it became apparent that this is one type of melanocytic nevus and not melanoma. Many years later, because Sophie Spitz described it first, it was called Spitz nevus, in honor of the pathologist. In fact, what she described in her original article, there were 13 cases, 12 of which were Spitz nevi, but one patient later died of metastatic melanoma. So it was a little bit mixed. This even then shows you how difficult it might be to distinguish under the microscope benign Spitz nevi and Spitzoid malignant melanomas. Spitz nevi are, again, benign melanocytic nevi that usually occur on the face of young children and adults. They are dome-shaped, pink, tan, or brown. And there are multiple publications, including books that are written on the subject, giving us histopathologic characteristics and criteria to enable us to distinguish between the two. And in most cases, it is easy to distinguish between the two because in Spitz nevi, the growth of the melanocytes is symmetric, as you can see on this picture, relatively wedge-shaped if they are compound. Then on higher power, we see these large nests of melanocytes that are vertically oriented. There are clefts between the melanocytes and the surrounding epidermis. The epidermis is hyperplastic with hypergranulosis and hyperkeratosis. Again, large nests with clefts and nests raining down vertically. The cells are large and epithelioid with prominent nucleoli and abundant pink cytoplasm. And in Spitz nevi, we often see dull pink globules, which are called caminobodies. Melanomas that resemble Spitz nevi, on the other hand, are different. This is a melanoma in a 17-year-old. Even at low power magnification, you can see how very asymmetric the lesion is and very deep, extending down almost to the subcutaneous fat. At higher magnification, you see that the cells resemble those of a Spitz nevi. They are large, they're pleomorphic, they have abundant pale cytoplasm, but here we see numerous mitotic figures, and the cells are very, very pleomorphic. Here is an atypical mitotic figure. So in most of the cases, it is easy to diagnose Spitz nevus versus Spitzoid melanoma. This is a very high proliferative rate, Ki67 in this Spitzoid melanoma. In the re-excision specimen, here is the scar and a nodule still left down in the deep dermis. The cells, as you can see, resemble very much those of a Spitz nevus and mitotic figures. The patient had a sentinel lymph node, half of which was replaced by metastatic melanoma. So you can see how difficult it might be at times to differentiate between the two. And it is not surprising that there have been multiple studies pointing to the great inter-observer variability and discordance in the application of the diagnostic criteria, even among expert dermatopathologists. In many cases in pathology, we have immunohistochemistry, which is helpful to differentiate certain lesions. However, in the differentiation between Spitz nevi and Spitzoid malignant melanomas, immunohistochemistry is not helpful. Cytogenetic studies, such as comparative genetic hybridization, may also be used. Melanomas have multiple chromosomal aberrations, 95% of melanomas. Nevi usually do not show DNA copy number differences. However, 20 to 25% of Spitz nevi show an isolated gain of chromosome 11. We went fishing, but we came empty-handed because fluorescent in situ hybridization is not very helpful in the differentiation again between Spitz nevus and Spitzoid melanomas. It might be helpful in so-called common melanomas, but not in Spitzoid ones. They might be a completely different type of melanomas. Now, what do we do when we are faced with the question, we have a young child with a Spitzoid lesion? Imagine if you're the parent of this child. Do we tell the parent the child has Spitz nevus, this is completely benign, and that's the end of the story? Or do we tell the child and the parents that they have malignant melanoma and there is a good chance that the child might die from this melanoma? You can see the dilemma and the difficulties that we as pathologists and dermatopathologists face very often. Many of us work on trying to solve the problem, and it's not easy, as you can imagine. This is also my passion, and I have been working on that problem for a number of years. In 2008, I established the Yale Spitzoid Neoplasm Repository to collect those cases, and as of now, we have about 3,000 cases of Spitz nevi and Spitzoid melanomas and cases in between, which is probably the largest repository in the world. And I say that because many other laboratories might have more cases, but they have not put them together in a repository. Now, my husband and I were having dinner with friends one day, and we were talking what everybody's doing, and I mentioned my interest in Spitz nevi and Spitzoid melanomas and the difficulties we have in distinguishing between the two. And this friend of mine, Craig Whitehouse, he was a graduate student when him and his professor, John Fenn, developed the electrospray here at Yale University in the Department of Chemical Engineering. And for that, John Fenn got the Nobel Prize in Chemistry in 2002. My friend was building mass spectrometers for many, many years, and he said, when I told him that only fresh tissue could be studied with mass spec, he said, no, there is a center that can study formalin-fixed paraffin-embedded tissue because all our specimens are formalin-fixed and paraffin-embedded. I had only 5 specimens that were fresh tissue. So he sent me to the Mass Spectrometry Research Center at Vanderbilt University to Dr. Richard Caprioli, who in '97 developed a special technique to study formalin-fixed paraffin-embedded tissue samples. So just for those of you who are not very familiar with mass spectrometry, it's a very powerful method to analyze metabolites, small molecules, lipids, DNA segments, peptides, proteins, by determining the molecular weight of molecules using a mass-to-charge ratio, or MZ. Here is how it happens. This is a MALDI time-of-flight mass spectrometer. Here is the tissue, the targeted tissue, and a laser beam hits the tissue. The ions fly through a tube and get collected here, and they produce the mass spectra. And of course, the mass-to-charge ratio is very important in this, but the charge is always 1. So basically, these are pure masses that are detected at the end. And the lighter the molecule or the ion is, the faster they fly through the tube. Now, matrix-assisted laser desorption ionization, or MALDI, imaging mass spectrometry, is capable of measuring larger molecules. It can also directly analyze tissue sections for relative abundance and for spatial distribution of proteins. Here is a formalin-fixed paraffin-embedded tissue. We have serial tissue sections, 5 micron thick. They are subjected to antigen retrieval, on-tissue trypsin digestion, and matrix application, and then mass spectra are collected. With MALDI, the tissue can be analyzed in large sections, or you can do laser microdissection and still analyze the tissue, hit it with laser, and get the mass spectra. MALDI can do two things. Tissue profiling. In other words, you can have tissue sections, you can mark the areas of interest, the blue and the red are areas of interest, and you can collect the mass spectra just from these areas, excluding things that you're not interested in. Imaging mass spectrometry is another thing that MALDI can do. The whole section is being subjected to laser energy, and then mass spectra are collected, and you can generate molecular images. So these are molecular images of different proteins in different areas of this mouse brain. Then finally, you can do identification of the proteins directly from tissue, which is very important. Now, how important is the role of proteins? Gene expression, as we all know, is very useful, and it's also useful in distinguishing melanocytic nevi from malignant melanoma. However, gene expression does not always correlate with protein translation and does not account for post-translational modifications. Protein expression levels in post-translational modification state, however, have fundamental effect on cellular function or dysfunction, because proteins are the main carriers of biologic activity. Therefore, measurement of gene activity at the protein level is more informative. Now, MALDI can analyze proteins and peptides that are involved in the development and progression of diseases, especially cancer, and can discover molecular signatures. These molecular signatures are usually composed of 5 to 20 different proteins that together result in a robust diagnostic patterns. Different cancers, different types of tumors have been studied, and their molecular signatures have been developed. Now, Spitz nevi and Spitzoid melanomas both show these large epithelioid melanocytes that have abundant cytoplasm, and therefore my hypothesis was that there will be differences on protein level which may be able to differentiate between the two groups. My tumor specimens consisted of tissue samples from Spitz nevi and Spitzoid malignant melanomas from the Yale Spitzoid neoplasm repository. Only unequivocal cases of Spitz nevi and Spitzoid melanomas were used in the study, and these cases had abundant and densely cellular areas of melanocytes tumor to be studied. Here is an example of a Spitz nevus, one of the samples that was studied, and Spitzoid melanoma. You see here how the lesion is asymmetric, very densely cellular sheets of melanocytes as opposed to nests in the Spitz nevus and numerous mitotic figures. So the design of the study was the following. To study things with MALDI, you have to have a teaching set of at least 25 of each group to develop statistically significant difference. So this is the training set, and after an algorithm was established, then it has to be validated on a validation set. And we studied a total of 56 Spitz nevi and 58 Spitzoid melanomas. The study was performed at the Mass Spectrometry Research Center at Vanderbilt, where 5 micron thick tissue sections were were prepared. One of them was stained for H&E, and I marked the areas of interest. For example, here is an area of only melanocytes, no epithelial cells, no vessels, no stroma for the tumor component, and here dermis in close proximity to the lesion for the tumor microenvironment component. And at the end, these circles are 300 microns in diameter. And at the end, this is how the marked sections looked. Now here is the whole technique. We cut two sections, which are serial sections. One is mounted onto a MALDI slide, which is specifically coated. The other section is stained for H&E. The H&E section is scanned with a high-resolution scanner, and the pathologist marks the areas of interest. Then the two images, the MALDI image and the H&E image, are merged together in Photoshop, and the coordinates are transferred. See, the coordinates are now established, and the coordinates are transferred to an acoustic robotic spotter for deposits of trypsin and matrix. So you can see here how this is the tissue section with the matrix spots, which are smaller than those to exclude any possibility of error. And then mass spectra are generated, and multiple cases may be studied at once. This is the acoustic robotic spotter, which has a capability of extremely precise spotting in these tiny areas to be studied. This is the mass spectrometer that we used, and you can see it's quite big. This is my collaborator, Aaron Seeley, who is preparing the mass spectrometer to study the samples, and a little movie to show you how the mass spectrometer goes from dot to dot and generates, and mass spectra are generated for every single dot with extreme precision. The laser hits the molecules. Now here are my results in this microphotograph for Spitz nevi. The patients ranged from 1 to 48 years of age with a mean age of 13, not particularly male to female ratio, different than 1 to 1. The follow-up was from 2 to 20 years, but the mean was almost 11. None of these cases recurred or metastasized, and all patients are alive. This is the distribution of the lesions, mainly head and neck, leg, and trunk. And again, as you can see, very few patients are above the age of 25. For Spitzoid malignant melanoma, the patients ranged from 29 to 89 years, mean 62. Again, similar female to male ratio. The depth of the melanoma was from 0.75 to 9 millimeters. The mean was 3.2. The follow-up was 1 to 21 years with mean of 5 years, and follow-up, dead of disease, 7, alive with disease, 7, alive, no evidence of disease, and lost to follow-up. Now, the analysis, the statistical analysis of the mass spectrum data was done by a computer-generated statistical models in the construction of the algorithm, and in this case the data was analyzed objectively. The classification model was then built using a generic algorithm to determine the combination of peaks that would differentiate between Spitz nevi and Spitzoid melanomas. After the algorithm was established, then the spectra in the validation cohort were studied based on the supervised learning from the training set. For the tumor or the melanocytic component, the method discovered 5 peaks or 5 proteins with the following MZ ratios that discriminated between Spitz nevi and Spitzoid melanomas. For the tumor microenvironment, 12 peaks were chosen by the method to be differentiating between the two components. Now, from each specimen, as you saw, there were multiple blue dots and multiple yellow dots. So the number of, and each dot represents a spectrum that would classify either as nevus or melanoma. So the number of spectra in favor of Spitz nevus and the number of spectra in favor of melanomas were calculated. And if the proportion of all spectra was in favor of Spitz nevus, was higher, the case was classified as a Spitz nevus. Otherwise, it was classified as Spitzoid melanoma. And here are some of the results. So here we marked the 5 proteins that were differentially expressed in Spitz nevi and Spitzoid melanoma. Now, a slightly higher view, so to speak, of one protein with a mass to MZ ratio of 976. It's higher expressed in melanoma and less in Spitz nevus. This protein with 1060 MZ was expressed higher in Spitz nevus and lower in melanoma. And you can see nice clustering of the Spitz nevi and melanomas everywhere. We tried to do protein identification, and we were able to identify 2 of the 5 proteins. One was identified as actin with a MZ ratio 976, and the other one was vimentin, which are ubiquitous proteins but apparently differentially expressed. Now, after we, through the algorithm, established the 5 peaks that were differentiating between Spitz nevus and Spitzoid melanoma, we tested it on the validation set. And here are our results. 29 out of 30 Spitz nevi were diagnosed correctly based on tumor, based on the melanocytic component, and 26 out of 29 Spitzoid melanomas were diagnosed correctly based on tumor component. Interestingly, 29 out of 31 melanomas were diagnosed correctly based on tumor microenvironment. So for Spitz nevi, we have a sensitivity of 97% and specificity of 90%. Spitz nevi and Spitzoid melanomas can be successfully distinguished based on our results using MALDI IMS analysis and based on proteomic differences in the two. Molecular signature of 5 peaks for the tumor was determined to be statistically significant in the training set for both Spitz nevi and Spitzoid melanoma. The proteomic signature for the tumor microenvironment contained 12 peaks, and 94% of melanomas were identified correctly based on proteomic differences in the tumor microenvironment alone. Perhaps growth factors, cytokines, and other components may be actively secreted in the immediate tumor microenvironment surrounding melanomas, whereas they are not present in such quantities near Spitz nevi. Using the data from the tumor microenvironment may be helpful in correctly diagnosing cases which may have equivocal results based on the tumor analysis. Now, this is the first study employing MALDI IMS as a novel tool in the evaluation of Spitz nevi and Spitzoid melanomas, and for that matter, in melanocytic lesions in general. There were some prior studies, but they were all on fresh tissue, so this is the first study in the English literature. Our study just came out in the February issue of the American Journal of Dermatopathology, and actually one of our figures made the cover, which is very nice. Imaging mass spectrometry may be a valuable adjunct to histopathologic evaluation of Spitzoid and other melanocytic lesions. It may be useful in cases which are histologically equivocal, and the firm diagnosis of Spitz nevus or Spitzoid melanoma cannot be made with absolute certainty. Mass spectrometry can identify proteomic differences in formalin-fixed and paraffin-embedded tissue sections, which we work with every day. It seems to be a reliable method based on our results to differentiate Spitz nevus from Spitzoid malignant melanoma, objective, fast, and relatively inexpensive in comparison to fission CGH. And this might have a great impact on future studies because identification of protein expression profiles which discriminate between Spitz nevus and Spitzoid melanoma may translate in tumor biomarkers that can be incorporated into standard diagnostic and even treatment strategies. Spitz-Nevus or melanoma, very fast story. 17-year-old boy with ocular melanoma. The entire eye was replaced by melanoma. A few months after the surgery of enucleation, 3 lesions developed, which grew to this size within a month. See how it's very irregular, bilobed. This was biopsied, and it showed a mixture of larger and smaller melanocytes. Here are the large melanocytes that very much resemble Spitz-Nevus. Large melanocytes, but also small melanocytes admixed. This is the second lesion, also a little notched, a little irregular. Similar picture, small melanocytes, even pigmented, admixed with some large melanocytes in the dermis. Is this a Spitz-Nevus or metastasis? Although the lesions did not look exactly like the melanoma, the melanocytes were different. We did mass spectrometry, and the melanoma, the uveal melanoma, classified as melanoma, and we did mass spectrometry on 2 out of the 3 lesions because there was no tissue in the third, and they classified as Spitz-Nevi. Interesting article came out in Nature Genetics describing germ-Y mutations in BAP1, which predispose to melanocytic tumors and uveal melanomas. So they have a few families with uveal melanomas and tumors very similar to ours, including large epithelioid melanocytes that we see in Spitz-Nevi and small melanocytes admixed with the other melanocytes. So this could be a very useful method to explore in the future. Now the next step is to study the lesions in the gray area that are the difficult lesions, and we cannot classify precisely whether they are benign or malignant. And these studies are on the way. I actually got cases from all over the world that are being analyzed, and I hope to have the results this week. I'd like to thank you, the Yale Spore in Skin Cancer, because I was able to do this study thanks to the private grant I got, and all these people that are listed. Thank you very much.